Imagine doctors injecting collagen into a patient's vaginal wall just to fix a basic urinary issue, right? And then suddenly those exact same patients start coming back and reporting this massive, unexpected improvement in their sex lives.
Right, which is just wild.
It's totally wild. But that accidental medical discovery is actually what birthed what we now call the G-shot. And it's become this huge, prominent feature in the totally booming field of aesthetic gynecology.
Oh, absolutely. The demand has just skyrocketed recently.
Yeah, you've probably noticed it.
Huh.
So today we are doing a deep dive specifically tailored for you, the listener, into a really fascinating intersection of anatomy and psychology. We've got a whole stack of clinical sources here about medical guidelines, diagnostic algorithms, the latest research papers.
And we're looking at a very specific, very critical medical question today.
Exactly. We are looking at how clinicians actually screen for a complex condition called Female Sexual Arousal Disorder, or FSAD, versus someone who, just has a localized lack of mechanical stimulation before they go and administer a G-shot.
Yeah, because it's a fascinating diagnostic maze, honestly.
Yeah.
You have a patient walking into a clinic requesting this cosmetic enhancement, a G-shot, because they're struggling with sexual function.
Right.
And the physician's entire job is to figure out, does this patient simply need a mechanical adjustment to increase physical friction? Or are they masking a really complex whole body condition like FSAD?
Which are two totally different things.
Completely different. And mistaking one for the other, that can really derail a patient's physical and mental health.
Well, let's start by outlining the actual mechanics of the G-shot itself, just so we have a baseline for the physical side of this equation.
That makes sense. So the G-shot is a trademark term. It stands for G-spot amplification.
Okay.
And the clinical literature describes it as targeting a very specific area on the anterior or the front vaginal wall. It's located roughly 2 to 3 centimeters inside the vaginal entrance, resting right under the urethra.
Got it. And that specific region is super rich in nerve endings, right?
Right.
And periurethral tissue.
Exactly. It's a highly sensitive area. So the procedure itself involves injecting a dermal filler directly into that tissue. Historically, like you mentioned with the urinary issues, it was collagen.
Right, the accidental discovery.
Yeah. But today, clinicians primarily use hyaluronic acid.
Which is pretty common in skincare and facial fillers too, right?
Totally. It's a substance that actually naturally occurs in the human body. It acts almost like a microscopic sponge. So it draws in and holds onto water.
Ah, okay. So when it's injected into the anterior vaginal wall, it physically plumps up the tissue.
Exactly. And it's done under local anesthesia, usually right in an outpatient setting. It only takes about 10 minutes.
Wow, that's fast.
Super fast. But because the body naturally metabolizes that hyaluronic acid over time, the effects are temporary, usually lasting anywhere from, say, 8 to 18 months.
Okay, so when you think about this mechanically, the goal is actually really clear. I like to look at the G-shot as essentially putting a specialized speed bump on a really smooth road.
I love that analogy. That's exactly what it is.
Right, because a woman might be struggling to achieve a coital orgasm, meaning an orgasm achieved purely through intercourse, just because there's a lack of physical contact in that highly innervated area.
Yeah, the anatomy just isn't quite aligning to provide the necessary friction.
So injecting that filler temporarily enlarges the tissue, makes it more prominent. You literally build a speed bump to increase physical friction and nerve stimulation exactly where it was lacking.
It's a purely structural intervention. The volume from the filler closes the physical distance between anatomical structures during intimacy.
Which enhances the localized arousal.
Precisely. Yeah. But the huge assumption here is that the patient's neurological pathways, their hormonal profiles, their psychological state, all of that has to be perfectly healthy and functional.
Right. The only missing variable can be the mechanical friction.
Exactly.
But if the problem is just a smooth road, the speed bump is a brilliant fix. What if the patient's internal engine isn't running at all?
Then building the biggest speed bump in the world isn't going to get the car moving.
Yeah, exactly. Because a localized lack of friction is incredibly straightforward compared to a systemic condition like female sexual arousal disorder.
Oh, without a doubt. FSAD fundamentally shifts the entire diagnostic picture. You're moving away from a localized anatomical issue to a systemic disorder.
And the diagnostic manuals have actually updated how they classify this, right?
They have, yeah.
Yeah.
In the latest diagnostic manuals, FSAD is now categorized under this broader umbrella. It's called Female Sexual Interest Arousal Disorder, or FSIAD.
Okay. And how do the clinical criteria actually define that?
So it's defined as a persistent or recurring inability to attain or maintain adequate sexual arousal. And the sources are really specific here. To meet the threshold for a clinical diagnosis, these symptoms can't just be like a temporary reaction to a bad week at work.
Right, everybody has stressful weeks.
Exactly. The symptoms must be present for a minimum of 6 months.
6 months. And there's a really important psychological requirement attached to that diagnosis too, right?
Yes, the symptoms have to cause marked distress or interpersonal difficulty for the patient.
Which I definitely want to explore in a bit because that distress requirement plays a massive role in how doctors actually prescribe treatments later on.
It really does. It's the key divider.
But first, I think it's important for you listening to understand how the medical field's view of female arousal had to evolve just to define this disorder properly. Because older diagnostic criteria, they viewed arousal through this really narrow, purely physical lens.
Oh, the older frameworks were heavily criticized by modern researchers.
I mean, they basically treated it like a light switch.
Pretty much.
Right.
They relied almost exclusively on physical markers, specifically just genital lubrication and swelling.
Right.
The medical assumption back then was that if the physiological signs of vasocongestion, increased blood flow to the pelvis, if those weren't present, the clinician would just diagnose an arousal disorder.
Completely ignoring the brain.
Entirely. He
Right.
completely ignored the cognitive and emotional architecture of human sexuality.
And the sources highlight this totally fascinating phenomenon that shatters that old physical-only model. It's called desynchrony.
Yes, desynchrony. This is such a crucial concept.
Right. It occurs when there is a complete disconnect between a woman's subjective, cognitive feeling of being turned on and her body's actual physiological response.
Right. So a woman can be completely mentally engaged, feeling intense desire and psychological arousal, but her physical body simply does not initiate that vasocongestion.
And the reverse happens too, doesn't it?
Exactly. The reverse is also true. The body might display all the physical markers of arousal, but the woman feels completely disconnected or cognitively disinterested.
Which just proves that female sexual arousal is this incredible complex whole-body neurobiological event. The brain and the pelvic organs have to, communicate flawlessly through the central nervous system.
When that communication breaks down, that's when an arousal disorder manifests.
Okay, so this brings us to one of the most mind-blowing studies in our source stack today.
Oh, the tactile sensitivity study, yes.
Yes. So researchers working in a sexual psychophysiology lab, they wanted to investigate how women with FSAD process physical touch compared to a control group of women without the disorder.
And what's brilliant is they didn't just limit their testing to the pelvic region.
No. They measured touch thresholds on areas totally unrelated to genital anatomy, specifically the fingers and the lips.
Right. So the methodology involved applying these varying degrees of physical pressure to the fingers and lips just to determine the exact threshold at which the patient could consciously register the sensation of touch.
And what they found is just staggering. They revealed that women with FSAD exhibited significantly decreased tactile sensitivity on their fingers and lips.
Yeah, it required measurably more physical pressure for their nervous systems to even register the stimuli.
Wait, so just to make sure I'm getting this, they don't just have localized genital numbness, they are experiencing a systemic dulling of tactile sensation across their entire body.
That's exactly what the data suggests. If a woman's central nervous system requires a higher threshold of pressure to register touch on her fingertips, it completely reframes the pelvic issue.
Wow.
It points to potential differences in how the brain processes tactile receptor signals globally, or, maybe even a lower overall density of touch receptors throughout the entire body.
Well, the implications for treatment there are just massive. I mean, if the root cause of the arousal disorder is a systemic neurological difference in how the body processes sensory input, then a localized intervention is just gonna fail.
Right, 100%. The structural issue of friction becomes totally irrelevant if the nervous system isn't adequately transmitting or processing the sensory data in the first place.
Right, because if the central nervous system isn't processing touch properly, giving a patient a G-shot is basically like upgrading the speakers on a stereo that isn't even plugged into the wall.
That is a perfect way to describe it.
I mean, you can enhance the hardware all you want, but without the electrical signal, there's no output.
Exactly. And this brings us right to the central challenge for clinicians today, because the root causes are so wildly different, right? A simple need for mechanical friction versus a systemic sensory or psychological disorder.
It's day and night.
It is. So clinicians have to run a really rigorous screening process. They need a reliable diagnostic algorithm just to separate the candidates.
So walk us through that. How do they actually do that diagnostic detective work?
Well, the clinical gold standard for starting the separation process is a validated screening tool called the Female Sexual Function Index, or the FSFI.
Okay, the FSFI.
Yeah. Doctors use this specific algorithm to map out the patient's sexual experience over the previous 4 weeks.
So it's a questionnaire.
Right, it's a 19-item questionnaire, and it breaks sexual function down into 6 distinct domains. You have desire, arousal, lubrication, orgasm, satisfaction, and pain.
Okay, 6 domains.
And they score it. A total score of 26.55 or lower across those domains, that flags the clinician that there is a clinical sexual dysfunction present.
Okay, I have to jump in and introduce some friction here on behalf of the listener, because relying on a 19-question survey as your gold standard, I mean, that seems incredibly subjective.
It does seem that way, yeah.
Human memory is flawed. A patient could easily misinterpret the questions or, just have a terrible month because they were super stressed, and that might completely skew their answers.
That's a really valid concern.
So how can a doctor confidently differentiate between a deep-seated neurological lack of arousal and someone who just had a bad month at work and filled out a survey poorly?
Well, the key is that the FSFI isn't designed to be a definitive diagnostic test in isolation. You don't just look at the total score and call it a day.
Okay.
Its true value lies in how the clinician analyzes the specific breakdown of those 6 domains to spot patterns.
Ah, I see.
The subjective nature of the survey is actually exactly what helps separate the cognitive experience from the physical reality.
So it highlights the desynchrony we were talking about earlier.
Exactly. By looking at the arousal domain, which really focuses on mental excitement and confidence, and comparing it to the lubrication domain, which focuses strictly on the physical response.
The doctor can see the disconnect.
Right. It helps them differentiate between female cognitive arousal disorder and female genital arousal disorder.
Okay, so the questionnaire is really more of a map. It just tells the doctor where to look next.
Precisely. And to counter that subjectivity and to rule out physiological causes that would contraindicate a cosmetic procedure like the G-shot, the algorithm mandates a really highly detailed physical clinical examination.
And this goes way beyond just a standard annual checkup, right?
Oh, way beyond. The physical examination searches for biological markers and structural anomalies that a questionnaire could just never detect.
What's the first thing they look for physically?
Well, one of the first physiological tests is checking vaginal pH levels.
Just with a simple swab.
Yep, a simple pH swab. And it reveals crucial information about the patient's hormonal landscape. A healthy vaginal ecosystem is typically acidic.
Right, maintained by lactobacilli bacteria.
Exactly, and those bacteria actually thrive on glycogen, which is produced by estrogen.
Ah, okay. So when estrogen levels plummet, whether that's due to menopause, certain medications, or other hormonal imbalances, that glycogen just disappears.
It does, and the bacteria starve.
So the pH becomes more alkaline, and the tissue itself begins to thin and atrophy.
Right, and that atrophy causes severe dryness and pain during intimacy.
So injecting hyaluronic acid into atrophied, estrogen-deprived tissue, that's not going to solve the pain or the underlying hormonal deficiency at all.
Not even a little bit. It would be completely ineffective.
What else are they looking for in the physical exam?
Clinicians also perform what's called a Q-tip test.
A Q-tip test?
Yeah, they literally physically insert a cotton swab into the urethra and ask the patient to bear down or strain.
Oh, wow. Okay. What does that do?
They're observing the angle of the swab to check for urethrovesical mobility. If the angle of the swab shifts dramatically, it physically demonstrates that the connective tissue supporting the bladder neck and the urethra is failing.
Oh, I see. And a cosmetic filler cannot repair compromised structural support.
Exactly. That requires actual surgical intervention, not a speed bump.
Right. Right. And the physical exam also includes a really thorough manual check of the pelvic floor muscles, too, according to the sources.
Yes. The clinician feels for hypertonicity.
Which basically means they're assessing whether the pelvic floor muscles are stuck in this chronic state of contraction or spasm.
Right. Because muscles that cannot relax restrict blood flow. And if you restrict blood flow, you make the physical vasocongestion required for arousal absolutely impossible.
They also inspect the area for clitoral fibrosis.
Yes. They're looking for heavy scarring from past surgical trauma, like episiotomies from childbirth.
Because heavy scarring can evidently sever or compress those nerve pathways? No, wait. This exhaustive screening process, I mean, you've got the intimate questionnaire, the pH testing, the structural exams. This feels incredibly vulnerable for the patient.
It is extremely vulnerable.
Which brings us back to that psychological requirement I flagged earlier, the distress.
Yes, the distress requirement is vital.
Because the clinical guidelines are firm that a low score on the FSFI, or even a lack of physical arousal, does not automatically equal a disorder.
It doesn't.
The defining line between a medical dysfunction and just a harmless variation in human sexuality is the patient's personal distress.
Right. And that distinction, it fundamentally respects patient autonomy.
Mm-hmm.
I mean, a woman might experience very low desire or minimal physical arousal, but if she's perfectly content with her sex life and it causes zero interpersonal conflict, she doesn't have a disorder.
The medical community does not classify her as having a disorder.
Exactly. Medical intervention is only ever triggered when the patient themselves identifies the symptoms as distressing.
I love that. So once the clinician has evaluated those distress levels, they've tallied the FSFI domain scores, and they've completed the physical and hormonal exams. They finally reach the critical fork in the road.
Right. The data dictates entirely divergent treatment pathways from here.
Okay, let's outline the pathway for the G-shot first. Based on this really intensive screening, the ideal candidate for this aesthetic enhancement is actually highly specific.
Very specific. It is reserved for a woman who has successfully achieved orgasms in the past, but is currently struggling with coital anorgasmia.
Meaning she's having difficulty reaching climax specifically during intercourse due to a localized lack of stimulation.
Exactly. And her screening has to show normal estrogen levels, healthy vaginal pH, strong connective tissue, and a relaxed pelvic floor.
So the engine is running perfectly, she just needs the speed bump.
Right. And, crucially, she must also possess realistic expectations. She needs to understand that the injection is a temporary mechanical enhancement designed solely to increase friction.
By contrast, the clinical guidelines explicitly list who must be screened out and completely redirected away from this procedure.
Yes, the contraindications are very clear.
The G-shot is strictly contraindicated for women experiencing primary anorgasmia, right?
Correct, meaning they have never experienced an orgasm under any circumstances at any point in their lives.
It's also not appropriate for pregnant women or women with severe vaginal relaxation who require actual anatomical repair like we talked about with the Q-tip test.
Exactly. And most importantly, if the screening reveals that the patient is suffering from true female sexual arousal disorder, whether that's driven by hormones, neurobiology, or psychology, the G-shot is taken completely off the table.
Because you'd just be masking the real issue.
Right. In those cases, the clinician pivots to evidence-based therapies that are actually designed to treat the systemic root cause.
So if the physical exam uncovered that pelvic floor hypertonicity, those chronic muscle spasms, the patient is referred to specialized manual pelvic floor physical therapy.
Yeah. A trained physical therapist actually works to physically release the chronic spasms in the musculature,
And relieving that high tone allows normal blood flow to return to the pelvis.
which naturally improves the pain, the arousal, and the physical ability to achieve orgasm.
What if the pH swab and the tissue exam revealed an estrogen deficiency?
Then the treatment pathway shifts to localized hormone replacement. Applying topical estrogen directly to the tissue gradually restores those glycogen levels we talked about.
Right, which normalizes the acidic pH, improves vascular blood flow, and literally rebuilds the structural integrity and thickness of the mucosal lining.
It reverses the atrophy.
That's amazing. And what about when the FSFI questionnaire highlights profound cognitive or psychological barriers, like indicating that desynchrony where the mind just cannot engage despite physical cues?
In those instances, psychotherapy or cognitive behavioral therapy becomes the frontline treatment.
Because you have to address the underlying relationship discord or the performance anxiety or, unresolved trauma that's literally interrupting the central nervous system signaling.
Exactly. The brain is the biggest sex organ. You have to treat it.
Yeah.
And, in some cases, the intervention is actually as simple as prescribing targeted vaginal moisturizers.
Really? Just moisturizer?
Yeah. To be applied regularly, completely independent of sexual activity, just to slowly restore cellular hydration and overall tissue health over time.
Wow. So the overarching takeaway from all this clinical data is that aesthetic procedures like the G-shot can be highly effective tools, provided they are applied to the correct mechanical problem.
Exactly. But attempting to mask a complex hormonal, neurological, or emotional condition with a cosmetic dermal filler is a profound disservice to the patient.
It just delays actual healing.
It does. And this really highlights why rigorous clinical screening algorithms are just non-negotiable in this field.
Right, because the female sexual response is this intricate interplay of vascular anatomy, endocrine function, central nervous system processing, and emotional state.
Untangling a simple need for localized friction from a complex systemic arousal disorder requires treating the entire patient. You can't just isolate and plump a single anatomical feature and expect a miracle.
It's a perfect example of how modern medicine really has to balance highly targeted structural interventions with a holistic understanding of the nervous system.
Absolutely.
So before we wrap up this deep dive today, there is a final concept worth pondering that really builds on that tactile sensitivity study we unpacked earlier.
Oh, the future of treatments.
Yeah, because
Okay.
the clinical data showed a clear link between sexual arousal disorders and a systemic decrease in tactile sensitivity across the fingertips and lips, right?
Right.
Well, if the root of some arousal disorders actually lies in how the entire body processes touch, the future of treating sexual dysfunction might look radically different.
It could change everything.
We might move away from focusing exclusively on the pelvic region altogether. Instead, we could see the development of whole body sensory retraining therapies.
Utilizing neuroplasticity.
Exactly, helping the brain literally relearn how to register and process touch on the hands, the lips, and the skin. That could actually become the key to unlocking systemic arousal disorders.
Retraining the nervous system globally to heal intimate wellness. It's an incredible thought.
It really is. Retraining the fingertips to fix the pelvic response. Mind-blowing.
Well, thank you for joining us on this deep dive. Keep asking questions, keep challenging the simple answers, and keep exploring the fascinating complexities of the human body. Until next time.